Today on the podcast, we are talking about rebuilding yourself. We are talking about rebuilding sciatica more specifically. In order, I think, to rebuild sciatica, we need to reframe and reorient ourselves as to what sciatica really is so we know the map. So when we go in, we're not hit blindsided by what's going on. So what is sciatica? Why is sciatica so common? Why do so many people get sciatica? How does sciatica really work? And then, of course, how do we get out of sciatica? How do we fix sciatica? What do we start to do to rebuild our sciatica? How do we rebuild ourselves with sciatica? Today on the Anatomy of Therapy. But first and foremost, welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Dr. Bobby Riley, and today is all things sciatica. Bobby, you brought this up. Why sciatica?
Well, our DMs are full of thousands of people with sciatic issues. And it seems to be a hot button topic, whether it's in the clinic or on social media. And I think it's just good to clear up, a lot of things around this term. It gets thrown around quite a bit. And then there's just the classic perfunctory movements that we're supposed to do for it. And sometimes that works and sometimes it doesn't. But it's really these questions like, hey, I have sciatica. Give me an exercise for it.
Yeah.
And that's not that's a non sequitur right there. So we're going to explain why that doesn't make any sense.
Absolutely. Yeah. Absolutely. These are, and if we haven't got back to your DMs, my God, there's a lot of them. It's really hard to get back to all of them. But sciatica is, and even in the clinic, I see it every day. People come in, they say they have sciatica. So just briefly, when people say they have sciatica, what do you think they're saying to you? Just the general person, right?
Yeah, probably they are just presenting with pain in the butt or pain in their leg or maybe anywhere around their hip. And I think sometimes they probably just have low back pain and they call it sciatica. But I would say something below the low back or around the hip. They're saying there's an achiness there, and that was probably what drove them to receive that diagnosis. Right?
Usually, yeah, I agree. Usually on one side, I actually Googled this just to see if there are any interesting sciatica facts. It says that there are 3 million self-diagnoses of sciatica a year. And sciatica is also usually a one-sided thing, right? So it's usually pain on one side, which is not uncommon. We're all kind of a little bit unbalanced. So a lot of times our pain can be on both sides and everywhere all the time, or it can be on one side and go down the leg. Now, one of the things I think that's important to understand about sciatica is it's kind of a blanket diagnosis for pain on one side or pain that goes down the hip or pain that goes down the leg, maybe even a little bit. And that's really not the patient's fault, honestly, right? Doctors have kind of, and maybe it's not even the doctor's fault if we take even one further step back, because insurance companies force a doctor to make kind of a linear diagnoses, and you should make a diagnosis of the primary cause and second differential diagnoses, right? And so when you say, hey, you have sciatica, patients think that it's almost like you went to the store and you got a gallon of milk and now you have a gallon of milk. And then when people DM us, they're like, hey, how do I get rid of this gallon of milk? It's not exactly that linear. And so we're going to break it down a little bit more specifically. There are things that could be sciatica-like. What is your short list for what sciatica might also be, if that's a good way to phrase that question?
Yeah, I'll come right back to that though with your thing about the doctors and the insurance companies. I was just thinking that one of the issues is, there's no problem between, if we're going to call it sciatica or we're going to code it whatever so that the insurance company knows what we're working on, that's fine because that's that relationship. But it's the problem is from the doctor or the therapist to the patient. Just because you code sciatica so that insurance companies know what you're working on all day long doesn't mean you look at the patient and tell them you have sciatica, because that doesn't really mean anything to them. It might if they have, but it's going to mean whatever the concept they have in their mind of sciatica is, right? Which just to directly define it, sciatica is called sciatica because it's irritation to the sciatic nerve. So anything that's not irritation to the sciatic nerve would not, actually be called sciatica. But I think it's fine for a patient to call kind of any radiculopathy sciatica because it doesn't really matter if it came from L3. In reality, we know it's L4, 5, S1, S2, S3, but it doesn't matter. So sciatica, something nerve related going down the leg, right? So
it's a good entry point to say sciatica. I agree with that. Yeah.
Yeah. I think sciatica, it's so enveloping as far as what it covers. It's more the specific diagnosis that sciatica is honestly blocking, I think, is more the problem. Because you say, what else could it be if it's not sciatica? I'm thinking sciatica covers pretty much a huge chunk of things going down the leg. So you say, well, what can cause sciatica might be a better question, because if we either have to ask two questions. One is, what causes sciatica? What are the reasons why we get it? Or two, what else could cause sciatic-like symptoms? And there's not a ton, if we're using the broad sweeping brush term sciatica, right? So so if it's typically sciatica is going to be, more down the back of the leg, the calf into the foot kind of thing, gluteal pain, that's going to be the primary issue, which is why a lot of times standard sciatica is often also diagnosed as piriformis syndrome, which is another side, which is just one reason why you can have sciatica is piriformis syndrome, for example. So that's one of many we can have, but by far the most common is a disc herniation. I mean, that is most likely why you have sciatica.
Yeah. And I mean, so some of the research says that, after the age of 35, there's a very high percentage that you have some degeneration in your discs, and that is completely normal. That's just like saying I've got wrinkles on my forehead. It happens. To what degree that degeneration impinges on those discs, and those discs then on the nerves and leads to sciatica is a whole nother story. So even if you do have some degeneration in your discs, it doesn't mean that you are going to have sciatica. But oftentimes that's kind of one of those precursors that gets us towards why you might have sciatica. So if I'm treating sciatica, or if I'm looking to treat sciatica, I'm also not just looking at stuff from the hip down the leg. So for instance, a lot of times patients seem to, with this, go, I have sciatica. I know I need to stretch my hamstrings. I know that but I just don't do it. And so what can I do for sciatica? This is, I think, one of the bigger, I don't want to say mistakes, but bigger misunderstandings in terms of sciatica. You have sciatica because you don't stretch your hamstrings. True or false?
That doesn't even make sense to me. I don't even know how to answer that question. Like that doesn't compute, period, in my mind.
I
know. I don't even know where that comes from, except from I can see that the question about the hamstring has to do with maybe the typical treatment for sciatica has a lot to do with neural flossing, which looks a lot like hamstring stretching.
Sure.
Or some kind of neurological tension of muscle being conflated with neural tension of neural tissue, which is something like sciatica. But otherwise, I don't think it matters at all if you have tight hamstrings or long hamstrings, as far as if that's going to be, it doesn't have a direct relationship to sciatica. You can have long hamstrings and have sciatica. In short, if you have a disc herniation pressing on the nerve, that's why you have sciatica. So your hamstring length is irrelevant to me, as far as, or not to me, to the individual that has the sciatica, I guess is what I'm trying to say. But there's, the reason why everybody is being told to stretch their hamstring is because they probably can't even straighten their knee when they have a lot of neural tension. So the therapist or the doctor checks this person's, and say, oh, you have tight hamstrings. You can't even straighten your leg at 45 degrees. And look, it's so tight. And that you have no idea if that thing is physically short or it's actually neural tightness. And if it's sciatic neural tightness, you can't stretch that away. So in that case, that's probably going to hinder them. And if you have, and if we'll come back to this, maybe it's too much all at once, but the neural flossing, which is to kind of free up that sciatic nerve, I sometimes use the kind of crude example of like the nerve. If I'm stepping on a dog's tail and the tail is the nerve, if I'm barely got my foot on it, that dog might be able to wiggle that tail free. And in that case, that dog's tail probably feels better. It's nice and free. But if I step hard enough on that dog's tail, his attempt to get free is only going to hurt him more and more. So this is the difference between the person who does a hamstring stretch or neural flossing, and then they just feel horrible for the rest of the day or the next 2 days, because all they did was yank on the nerve that it cannot floss. So yeah.
No, that's great. I want to take one step back. When you're talking about neural tension, I just want to make sure that we are kind of explaining like precisely what neural tension is. Like, so there could be like disuse atrophy in your muscle. You could get tight because you just never move your hamstring. Okay. So like the tissue, the actual hamstring could just start to get tight because you never straighten your legs. You just sit down all day and that's it. And you never straighten your legs nor touch your toes. Okay. There's another type of tension that Bobby's talking about, neural tension, where the nerve component tightens up that tissue regardless of the actual tissue of the hamstring being tight or loose. So the nerves have control over the muscles to some degree. And if the nerves, and this is kind of like when someone throws their back out and their back spasms up and those muscles spasm up in their back, right? Many of us have experienced this or seen somebody who experiences this, and those muscles are so tense, they will not let go. And so it's not exactly neural tension, but your central nervous system has kind of overridden your manual control of the tension in your muscles, and the nerves are controlling the tension, not necessarily the extensibility of, say, like my shirt going back and forth. Like your brain is kind of like, no, this is not going anywhere. We've decided it's not healthy for you to do that. So, and that usually happens when there is some sort of threat, some sort of perceived threat that your body has gone under and been like, ooh, if you move this, it's going to cause more serious problems. And so that is neural tension. Is that a fair kind of definition?
Yeah. And I think an easy way to put this is like, there's cases where you take a patient and you knock them out under general anesthesia and you can put them in the splits. But then when they become conscious, they may not come close to being able to do the splits because now the brain's back on and perceiving threat in a sense. So it's the regulator, like on the car, that keeps it from going more than 95 miles an hour. It creates a new set point of tone, right? Perfect. And most therapists should know this, but I mean, this is, something that I think, for some reason just gets kind of jumbled up into the mixture of whether it's muscle tone, the neurological or mechanical tone, and then true neural tension, where a nerve is actually not letting your knee straighten. And to be honest, you can have both, because if you have long standing sciatica, so you have somebody who's had it for years or months to years, well, then they might have a combination of both, where they haven't really been able to stretch their hamstring because the neural tension is so high. Now they've gone 2 years and now they have actual adaptive shortness of the hamstrings. So now you have both, right? But the neural one is the one that's going to set the pace for the recovery.
And just to see the other side of the spectrum, one of the things that I've been slipping into our Instagram reels is, with these challenges that I'm posing, 50 and 100 reps of these certain things, there's this other thing called grooving a pattern, right? And so your body, once it starts to habituate a thing, it becomes easier and more natural. So there are 3 sets of 10 is kind of a normal thing for exercise. They discovered that back when they were trying to exercise people after they came up with after polio back in the 50s. They're like, you guys are weak. 3 sets of 10 is the most optimal for the general population. And that's true. The reason I'm giving 100 or 50 reps is so that you really groove that pattern. Your body's really going to figure out what the heck is going on. So in terms of stretching and long-term results, it's kind of the opposite end of that spectrum of the neural tension, or creating a new neural tension, a new normal for your body that will also groove the nerves, but then also the soft tissue will begin to kind of wear and tear and groove into that new kind of 100 rep position. But let's go back to sciatica. Where were we left on sciatica? How does sciatica come about? We've kind of talked about possibly the soft tissue getting tight, possibly creating some neural tension, most likely stuff coming from your lower back, probably not tight hamstrings. What have we left out so far? Why might,
Yeah, well, so straightforwardly, it's most likely coming from a disc bulge, right? Some type of disc pressure on an exiting nerve root, some foraminal encroachment, possibly central canal. So if somebody has pain down both legs, it might be more of a central herniation or broad base bulge, something like that. But just to understand, it's going to be coming mainly from these discs. Okay. After that, you can have a bunch of rare stuff. And you have like semi-rare stuff that would be just stenosis, where there's narrowing of the canal, maybe because of bony changes, osteophytes, things like that. Or you can have like piriformis syndrome, entrapment of the nerve underneath or piercing the piriformis. Those are semi-rare, right? And then you have things that are like more super rare, like tumors and Tarlov cysts that happen to sit in the sacrum at a certain position that give you the same feeling, basically, of a disc herniation, which is the main reason for sciatica. But I mean, 9 out of 10 of these people, it's going to be coming from their low back in some form. You can also have spondies that where the bone slides forward and kind of encroaches on a nerve, so you're going to get some neurological symptoms. That's also like a semi-rare one. It's fairly common, but nothing like sciatica that's coming from a disc bulge.
Right. And so one of the other things I have noticed is that these are the rare things. And I want to turn again to the other side of the spectrum, the more common reasons, because if you have a fever, if you have an infection, a viral infection, we can do lab tests to confirm that you do indeed have an upper respiratory infection and that you need these antibiotics. If you have sciatica, there isn't really a lab test specifically. There's not really imaging. There are groups of orthopedic tests that we kind of clump together that say you have a higher percentage of having perhaps sciatica, and we can diagnose it. But more so, I have found common reasons that people have sciatica goes back to things like tendonitis in the hip, like disuse atrophy in the hip. And I'm not saying poor glute activation, but there are some just kind of more general reasons why you might have sciatica. Good Lord, that was a pause, right? So let's go back to the soft tissue going away. The more common reasons that people have pain down their leg, their low back is probably a big part of it. Now, why is their low back a big part of it? One of the main things that I go through very often is a pretty simple line of reasoning, where in the body, generally, there are 2 types of muscles: fine movers and prime movers. Okay. Fine movers, like stabilizers, the small muscles of your back, they're small, right? They're the paraspinal muscles, the QL muscles that attach to the back of your spine are in fact stabilizing and quick firing small muscles. Then you have muscles in your hips that are more like prime movers. Okay. And I'm generalizing very deeply here, but they basically, prime movers should move first. Okay. There's a split second thing where the stabilizing muscles do stabilize the back, but primarily your glutes need to be doing the primary work. There's a third phase that I don't want to get into, but there are no muscles that attach to the front of your spine. The only stability that you have to stabilize the front of your spine is the pressure in your core. And that probably deserves a whole podcast on its own, with breathing and exhalation and what the core actually is. But one of the easy ways, I think, to end this podcast on something useful for y'all, how do you start to deal with some of your sciatic problems yourself, is to go after and work on your hip mobility, hip stability, and hip strengthening. That's kind of the first line of defense when I start thinking about how to solve sciatica or sciatica-like symptoms. How wrong am I? Do you agree with me?
I agree with most of it. I do agree with the idea. I'd be nuanced with this idea of going after your hip, because I would say you can go after anything reasonable.
Yeah.
And if, let's say you're already a clinician and you're listening to this and you yourself have sciatica, so you're going to have a better methodical process to self-evaluate. Sure. So what I mean is you can go and try flossing, and you'll get some feedback of whether that helped or not. Or you can go do a pigeon stretch and say, well, that helped. I thought it helped, but then 20 minutes later, my heel was burning 5 times worse than before I started the pigeon stretch, right? Mm-hmm. So what I'm saying is the person with the wisdom to understand what they're doing, you go through whatever tests or self-experimentation or exercises you want, and you get the feedback that's going to give you the answer to solve, because there's like no fix for sciatica. That's like saying, you know, how do I fix my hip bursitis, my shoulder impingement? But all depends on why your shoulder is impinging. Like there's no answer for that. It's impossible. So all the answers on Instagram are basically like, when they ask for, hey, I have sciatica, give me an exercise. If there's no more nuance to the question, it's basically the response is, go see a therapist near you or some kind of trainer who can guide you through this thinking process. That's why I meant you have to be the therapist. You have to have some type of a process or understanding of the body to get the feedback, to know what to do with it. It's difficult, but that's why you should go pay somebody, or that's why if you are the person that's getting paid, you should be trying to take patients through this process, not hey, you have a disc bulge, that's why you have sciatica, lay down on the table, I'm going to rub that area, and then we're going to crack that area. It's like, okay, that's better than nothing probably, but let's get more nuanced. Okay, so if there's sciatica, where is it entrapping? And how could you possibly figure that out? Maybe you figure it out because, well, regular McKenzie's doesn't do anything, but when you do a side glide McKenzie's and you do it the wrong way, it just completely fires them up. Maybe they have more of a lateral compression on the nerve, right? Mm-hmm. If McKenzie's makes it worse, maybe they have quite a big bulge right in the area where the you know, kind of facets or the lamina are sitting, you know? Yeah. Oh yeah, big bulge. And in other words, yeah, you have to tease these things out. Like when they say, okay, you have pain in the butt. Okay, you probably have piriformis syndrome. No. Most chance that's coming from the back. Piriformis, did they change anything in their life? Did they go from a desk worker to all of a sudden running ultra marathons? Because that might explain their piriformis syndrome. But otherwise, that's kind of rare. Chances are you want to do a bunch of low back tests. But see, these are the things that are going to tell you what to do. This is McGill 101. He says, find out if that spine can handle shear. Find out if it can handle compressive load. Find out if it can handle torsion. If it can, train it. If it can't, watch out for that one for a little bit, right? And then you can work on these things. So when you say, you know, if you look at one of the exercises that we give, or where John's showing on Instagram, it says try it 100 times, you're going to get feedback from that. It doesn't mean it's going to fix your issue, but it will give you feedback. And now the question is, do you know what to do with that feedback? But often we are showing exercises that are lower risk, that have a high reward. So they may have this great payoff where just by increasing hip mobility, you may do a bunch of things. Maybe you decreased peripheral compression or some kind of piriformis syndrome. Maybe you allowed hip mobility to take compression off the spine because the person was compressing everything with their spine because they had no hip mobility. On and on and on and on, right? So these things are low risk, worth trying, but if they hurt, you kind of have to figure out why that would be, right? And there's some cases that there's just certain situations where they just take time as well. So,
no, well said, bravo, great rant. I mean, that's the whole thing with those exercises I post up. They are, one of those things is not going to fix your back. I'm not that silly. And I think that this one exercise is going to fix all of your pain. The feedback is the big part, right? And do you know what to do with that feedback? I love what you said about, you know, sussing out, and Super McGill. I want to sparse it out just a little bit more and then we can end on this. But like the back, when patients come in, rarely will they tell you, my back hurts from flexion to extension, or my back hurts from neutral to extension, but it doesn't hurt from extension to flexion, nor does it hurt from flexion and rotation to the left, but flexion and rotation from the left to the right, it does hurt. And so you need to kind of suss out and pick out, if you're a clinician, some of these very specific movements that are provocative. Now, if you can find movements that are not provocative, that still use the joints that are provoked in one motion, but not provoked during another motion. That's what Bobby's saying. You can train those pain-free motions, and that's where you can get a big bang for your buck. That's your entryway into the system to make a change. And then what I do is if I find that window, I pound 100 reps into that. There was an episode we were talking about your shoulder mobilization and your hip mobilization. Go back and listen to that one. Bobby found a window into the system, and he was just driving a lot of change into the joint that was hurting, but in a non-painful and productive way. Like, that is the biggest key. And that's the big thing that I'm trying to do with these silly little reels on Instagram with the drawing on the thing and the cuts and all this stuff. They're very safe. And a lot of them are just great hip mobility, easing up of the back pain, and hopefully nice ways in to make a bigger change. And so if you have those things, and this is one of those things, if you're in pain, go work out. People saying I have back pain, I have sciatica, I can't work out. There are about 50 things you could do in the gym that are non-painful that will benefit you. Find those things that are non-painful, go do them, get stronger. Thank y'all so much for tuning in. Have a great week. You got one more thing. You better end it on a good one.
I was going to say, we get messages about this whole 100 reps or hold that stretch for 3 minutes, and people are mind blown. And I'm thinking, okay, that makes a little sense for the patient, but if clinicians are also mind blown, this is where we've hit on this on the past, this idea of like, you're not doing enough, like you're not giving enough stress to the body. So people are surprised by 100 reps or a 3-minute hold. I think you might be surprised that when you give enough stimulus to the body, you actually might force a change. You know what I mean? This 30-second heel to your butt standing stretch is not going to win the battle if you're an international pilot. It's not going to win the battle of the 16-hour flight from Singapore to New York City, and then you get off and hold your heel to your butt while you're in line at Sbarro's. It's not going to make up for it. And I think people need to, maybe whether it's clinicians or people listening that are in pain, if you can shift your mindset to say like, yeah, maybe it takes a little more stimulus than we think. You know, like I use that example of the 16-year-old trying to gain muscle. Like they think, I'll just take this creatine, I'll turn into Arnold Schwarzenegger. Like, no, it takes extreme work to accomplish goals, and it takes quite a bit to even accomplish a modicum of success. So I think, you know, I just wanted to, you know, touch on that because we get a lot of messages on those. So.
No, it's the same guys that also, we have a bunch of comments that will be like, or just squat. And I'm like, you haven't obviously listened to our podcast. I would love for people to squat, but the idea with squatting is to get a lot more load into your body in a safe way. And not everybody's going to go to the gym. I'm trying to apply that same concept to a silly little pigeon on the wall or whatever. Anyways, whatever. We love your comments. Keep them coming. Comment on the podcast, share it with someone. Thank y'all so much for listening. Sciatica, we're out. See y'all next week. Peace.
Take care.